bronchioles in the lungs. As far as the head and neck goes, it pretty much is associated with the lower portion of the pharynx, the throat, which would be consistent with the area behind the oral cavity and below the oral cavity. So we would call the oral pharynx and the hypopharynx. We'll be talking about that in the next 2 weeks. So what we're looking at here is, in particular, is this ganglion. Let's see if we can get this to work here. Is this ganglion over here, which is receiving input. There's another ganglion here, which is receiving input from here. Okay, so this is the sympathetic trunk. This little ganglion down here is actually the middle cervical ganglion. And this one up here is the superior cervical ganglion. Now, these two ganglion are receiving their input from below. Where is the okay? There it is on the floor. All right, so they are receiving input from the preganglionic fibers of the sympathetic nervous system. Once again, where are the preganglionic cell bodies of the sympathetic nervous system? Huh? Where are the cell bodies? Where are the preganglionic cell bodies?
Central nervous system.
What?
Central nervous system.
What part of the central nervous system? T1 through L2 or 3. Gray matter. It's called the lateral horn or the ipsilateral gray column. Okay? And so that has cell bodies anywhere, some people think as high as C8 and as low as L3. However, though all of that does not go to the head, really only the first 5 thoracic spinal cord levels ascend into the head, okay? Now, it's interesting because if you remember when we were in the thorax, we talked about the cardiac plexus. And the cardiac plexus was merging of parasympathetic fibers pretty much coming from the vagus nerve preganglionics and the sympathetic nerves coming from the thoracic spinal, okay? So they ascend, some of them ascend quite a distance up into here. T1 to T5, everything here in yellow, these are the preganglionic pathways. Everything that is coming out of here is from that are the postganglionic fibers that are going to the effector organs that are going to be innervated. What's the primary thing that the sympathetic nervous system innervates? What's the primary thing? Just take a wild guess. Vascular smooth muscle, arteriolar smooth muscle, okay? What other thing does it innervate in the head? Does the sympathetic nervous system innervate in the head? How? Speak up.
Dilation.
Dilation of the pupil of the eye, right? What else? What about this palpebral fold here? What's that? That's the upper eyelid. Okay, does it help lifting that upper eyelid? Okay. Okay, these are things that'll be on boards, by the way. Okay, both from the standpoint of head and neck growth, but also from the standpoint of neuro. Okay, we'll talk about it again. Okay, so those come up here. Now, some of them, you see these fibers here, these postganglionic fibers here, they dropped off onto the carotids. They're actually going down here. What's down there? Why are they going down there? What are they going to innervate down here? The heart, bronchioles. Okay? So those postganglionic cells for things such as the heart and bronchioles from a sympathetic perspective are actually arising from this ganglion up here, this superior cervical ganglion, and this ganglion down here, this middle cervical ganglion. There's actually another little ganglion way down at just behind the clavicle called the inferior cervical ganglion. But every postganglionic fiber or postganglionic structure associated with the head, in particular the vascular bed of the head, also the carotid plexus associated with the deep petrosal nerve, okay, and the innervation of the levator palpebrae superioris and the dilator pupillae of the eye, they are receiving the postganglionic fibers from this ganglion, okay? Where do the constrictor fibers, what are they associated with? Constrictor of the pupil of the eye, what are they associated with? What part of the nervous system?
Parasympathetic.
Parasympathetic. Okay, what cranial nerve does that? Constrictor of the pupil of the eye.
Breathe.
Ocular motor.
Right, oculomotor, okay. Oculomotor. All right. Are there any other parasympathetic cranial nerves?
Yes.
What are they?
Facial.
Trochlear and abducens.
No.
Abducen?
Abducen.
Abducen. You want to call a friend on that one? Okay. Oculomotor is the highest. Facial, glossopharyngeal, cranial nerve 9, and then the vagus. Okay? Those are things you have to know. I'm sorry. You're administering a lot of therapeutic agents, or your patients are getting a lot of therapeutic agents that are primarily used to control the autonomic nervous system in relationship to the vasculature, secretion of glandular areas, the digestive tract, bronchioles, heart, blood pressure, and so forth. You got to know what that's about. All right, so all of these postganglionics are going to the head, upper neck, are going to come from this superior cervical ganglion. This is the highest sympathetic ganglion. We'll actually see this in the laboratory. By the way, I'll be in the laboratory tomorrow afternoon doing this in this section. If you want to stop by, and I'll be there Saturday morning from 8:30 to 10:30. Okay. All right, so let's look at cervical. Let's look at cervical vertebrae. Okay, so how many cervical vertebrae are there?
8 or 7.
7. How many cervical spinal nerves are there?
8.
Now, why does that happen once again?
C1 comes from above.
Comes off on top of the first cervical vertebrae instead of below, right? All right, so some typical things about a cervical vertebrae. Vertebrae are defined usually by some of the processes, including the spinous process, but in particular, the transverse process of a cervical vertebrae has a foramen in it. And no other vertebrae in the body, in their transverse process, has a foramen in it. They may have a vertebral canal in the center, transmitting the spinal cord, but they do not have a foramen in their transverse process. And this foramen is referred to, therefore, as the transverse foramen. And what goes through it? We talked about this the other day.
Spinal cord.
What?
Spinal cord.
The spinal cord goes through the transverse foramen?
So all the spinal arteries and
If
things.
it does, you got big trouble. Okay.
Accessory.
All these nerves.
No.
vertebral artery.
Vertebral artery, vertebral veins, okay, for the most part, except in C7 where it's just the veins that are coming back in. Okay, what's a vertebral artery branch of? What's it a branch of? Just talked about this.
Subclavian artery.
Subclavian artery, it's the first superior branch of the subclavian artery. Okay. All right, the other thing that is somewhat typical, not all cervical vertebrae have this with their spine, but the spine is split like a fork, so it's said to be bifid, okay, split in two. So these typical cervical vertebrae will have transverse foramen, all of them have transverse foramen, C1 all the way down to C7. And most of them have a bifid spine. C1 we'll see does not have a bifid spine. And also C7 does not have a bifid spine, and sometimes C6 as well. Okay. So what are the ones that are atypical? Well, a vertebrae typically has a body, it has pedicles, it has lamina, and it has a spine. Okay. However, C1, it has no body. Okay, it has no body. Okay, and it has a posterior tubercle bump, but it does not have a spine. Okay, what happened to its body? I don't know if Dr. Thoreau talked about this or not. What happened to the body of C1?
The dens goes through the body.
What does it do?
The dens of the C2 goes through it.
Okay, the dens it was the embryonic body of C1. Where is the dens associated with which cervical vertebrae?
C2.
C2, okay. So this is the atlas, the head sits on the atlas, atlas holds up the world, this is our world up here. And so, but there is no body, because C2's Dante process or dens has to sit in there, okay? So it has a tubercle but no spine, does not have a bifid spine. C2 has this odontoid process, it's referred to as the axis. This is the superior portion of the body of the vertebrae is C2, it's associated with C2. It does have a bifid spine, by the way, okay? And it does have a transverse foramen. So the thing that it doesn't have, or the thing that it has in addition to its body, is it has this superior vertical projection, tooth-like projection called the dens or the odontoid process. Okay, and then C7 has a transverse foramen, but its spine is very long and it is blunted at the end. And I think I've told you this before, we're talking about the vertebral column. If you feel in the back of your neck, you can feel this tuberosity of C7 projecting off the back of your neck. That's the transition between the cervical vertebrae and the thoracic vertebrae. So everything from there up is cervical, everything from there down is thoracic. All right, so let's look at, here we see this image in relationship to the 7 cervical vertebrae. Here we see them looking from front to back. So here is here is C1 up here. It doesn't have a body here because it has given its body to C2 to form this odontoid process or axis. This is C2, C3, C4, C5, C6, and C7. Each one of them has a transverse foramen on each side of their transverse process of these vertebrae. If we look at them from the side, we see here's C1. It does not have a bifid spine. You really can't see that very well here. Okay, just has a little bump on the back. C2, we'll look at a C2 more closely. It does have a split spine or a bifid spine. C3, you can kind of see it here. C4, you can see the split. C5, a little bit in C6. Sometimes C6 looks more like C7, but here's C7. Look how much that protrudes off the back of your neck, and that just has a tubercle or a bump, as opposed to a split spine. So if we look at these individual vertebrae here, we've got C1 and C2. These areas here are called articular facets, okay? They are points of articulation between vertebrae, or in this case, this is the top of C1. This is the front. There's a little bump in the front of it, as well as in the back. So there's an anterior tubercle and a posterior tubercle. These are lamina back here. The pedicles are very short over here, okay? So what is sitting on these facets? What is sitting on those articular facets? The occipital condyles. We'll look at another one, we'll see that down below, the inferior facets that are articulating with the upper area of vertebrae 2. Here you can see that here's the bifid spine here, here's its lamina, and here's its pedicles over here. But these are smaller, and the articular facet on the atlas down below is going to be smaller as well. Okay, but the occipital condyles are much broader and essentially anterior posterior. Okay. If we come down here, here's a typical vertebrae. Here's the fifth cervical vertebrae. Here's a good example of a bifid spine. Here's the body. Here's the transverse process. Here's the transverse foramen. Here is a pedicle right here. Here is a lamina right here. And then here is the spine. Okay. Here's the seventh cervical vertebrae. Once again, it's an atypical because it does have a body, it does have a transverse foramen, but it does not have a bifid spine. It has a tubercle, or a spinous tubercle on the back. So that makes it a little bit different. Okay, once again, looking at C1. Looking at it both, looking down on it from above, here we see these large superior articular facets that are going to engage the occipital condyles. Once again, you would expect in a vertebrae to see a body right here in the anterior area, but we don't have a body because this is given up during embryonic development to be the odontoid process of the second cervical vertebrae, okay? So sometimes actually what happens during development is that the odontoid process doesn't form, and these two vertebrae, 1 and 2, remain fused together at their bodies, okay? So what would that do in relationship to the movement of your head and neck? Okay. What would that do? The vertebrae were, the first two vertebrae were fused. What does this axis, this rod, allow us to do? It allows us to turn our head from side to side, right? Just to say no, okay? So the ability to move our head forward is just between the occipital condyles and the first cervical vertebrae, or to nod yes, okay? So if you have a fusion here of the body of the first cervical vertebrae to the second cervical vertebrae, you would not be able to move your head from side to side. You could move your head and neck from side to side, kind of like this. Okay? But that's about as good as you can do. Okay, here are the inferior articular facets that would articulate with the second cervical. Here, looking down on the axis, we see the dens. We see the front of the bifid spine is a little bit more pronounced than the back. Here, these are the superior articular facets, so C1 is going to be sitting on these facets, and it is also going to rotate around this structure here, this odontoid process or dens. And then the vertebral column is going to sit in this vertebral canal between the front of the vertebrae and back, or surrounded by its lamina. Here we see the underside of C2, so we don't see the dens here because it's sticking up superiorly, but we do see the bifid spine here in C2. Here's the lower portion of its body. The dens, the odontoid process would be on the opposite side of this. And these are the transverse foramen. We have all these vertebrae in the lab, so we'll be able to look at them more closely. But these are the transverse foramen. What goes through them again? What goes through transverse foramen?
Artery and veins.
Vertebral arteries and veins. Okay, now throughout the vertebral column, we have ligaments. What's the role of ligaments in the body?
Organ to organ.
Bone to, do they connect bone to bone, organ to organ? Okay. Do they provide movement? What do? They limit movement, right? So we're gonna go, Dr. J said, you and I are gonna sit down and talk about ligaments. There's nothing I do in this fact. So there's a very long ligament that comes from the front surface of the sacrum and ascends all the way up the front of the vertebral body. For those of you who were in the HoloLens lab the other day, I mean, if you saw on the front of the vertebral column, they had that ligament. They had that ligament in front there. It was kind of a pinkish grayish color, okay? Running all the way up the front of the bodies of the vertebrae. This is the anterior longitudinal ligament. Now, when it gets to the very first vertebrae, on the front of the very first vertebrae, it then comes off and attaches to the skull. So this very first vertebrae is the atlas. So, and the base of the skull is the occipital bone. So, surrounding the foramen magnum. So this changes its name from anterior longitudinal ligament to anterior atlanto-occipital membrane, interconnecting the front of the first cervical vertebrae to the front of the occipital bone in front of the foramen magnum. On the inside of the bodies of the vertebrae, or inside the front of the vertebral canal, is another ligament that comes from the inside of the sacrum, the sacral canal, and ascends all the way up, basically parallel to this ligament. And as it comes up to the very first vertebrae, it actually comes across the back of the odontoid process and ascends into the cranial ball, and basically creates a root over the odontoid process and attaches to the inside of the occipital bone in the front part of the foramen magnum. So the anatomical word for a roof-like structure is tectum. So this is called the tectorial membrane as it goes basically from C2, crosses over the odontoid process and attaches to the occipital bone in front of the foramen magnum. Then we have ligaments that go between the spines of the vertebrae, the spine tips. These are called supraspinous ligaments. And they will then, as they come up to the first cervical vertebrae and go to the occipital bone, they will become the posterior atlanto-occipital membrane, or ligament, providing some extra support in the back. And then we have a ligament here that's kind of interesting, that basically is associated between cervical vertebrae 3 and cervical and the inside of the cranial bone. And it has a relationship where it has it looks like a large cross. It looks like a large plus sign, okay? And the center of this goes into the cranial ball and attaches there. But there is a large strengthening band, a very thick band, that goes behind the odontoid process, where the odontoid process is coming off of the top of the body of the vertebrae of the second cervical vertebrae. Okay? And so this is called a transverse ligament, or the transverse portion of this cross ligament, or the transverse process of this cruciate ligament. And it's really important because this is actually doing two things. One, it is holding the atlas to the axis, okay? And secondarily, this is actually serving as the articulation for moving your head from side to side. Once again, this is kind of an interesting thing because we typically don't see soft tissue structures act as an articulation, but in this case it does. We're gonna be looking at a lot of sagittal heads soon, sagittally split heads down the middle, and we will see this crossing over behind the odontoid process in those heads. Okay. So this is the cruciate ligament, or the transverse process more specifically, or the transverse portion of the cruciate ligament. Then there's a ligament that comes off of the tip of the odontoid process and attaches on the inside of the foramen magnum to the occipital bone. And then there are a couple little wing-like ligaments that come off the sides of the odontoid process and attach to the lateral borders of the foramen. So all of these ligaments here, these upper ligaments, are trying to hold the head onto your neck. Okay, good idea. You know, we don't typically have brain-body separations, although those are typically done with a hatchet, or a saw. But these are holding the head onto the cervical spine. Okay, onto the cervical spine. How do you think that this ligament, this cruciate ligament, we'll look at it shortly, could be torn? What do you think one of the most common ways in which it would be torn in a patient or in a population?
Turn too hard?
Okay. You ever had whiplash yourself, or heard of whiplash, where all of a sudden the car stops suddenly, typically because there's something in front of it that's not moving when it hits it, but your body keeps moving, your head jerks forward, and the whiplash injury, you can tear this transverse portion of this cruciate ligament. Okay. What's bad about that? What's the issue? What's the most serious thing that could happen? What's the most serious thing that can happen here? How about death? How about that? And why does that happen? Where was the respiratory center? Where was the respiratory center that was controlling your breathing? What part of the brainstem was that in? The medulla, okay? And so pathways associated with that were either coming or going from there. And where were they going? What were the primary structure that was basically controlling their breathing? What's the primary structure that allows us to breathe? The primary muscle?
Diaphragm.
Diaphragm. What's that innervated by? What's the highest nerve associated with the phrenic nerve?
C3.
Okay, so this is above C3. Any cervical spine injury above C3 will interfere with the ability to breathe. It will stop your respiration because it will separate the respiratory center from C3 and below. Okay? So, probably the most famous individual or infamous individual who recently had this type of an injury had it in an accident where he was riding a horse and fell off the horse and his neck got twisted forward quite a bit and he fractured his neck at the upper level of C1, C2, above C3. Okay, that was Christopher Reeve, Superman. Okay. So he had to be, for a while, he actually went, the Cleveland Clinic had developed a very sophisticated breathing apparatus for him that was more kind of electronic than those in the past. Individuals in the past that, for example, had upper cervical spinal cord injuries or had a condition called poliomyelitis, where they had to be put inside a large respiratory tank called an iron lung. Okay, but we have much more sophisticated breathing devices now. Okay, so let's look at these ligaments. Okay, so here is the anterior longitudinal ligament running on the front of the vertebrae. These are lumbar vertebrae, by the way. And then Here in the back would be this posterior longitudinal ligament back here, and this would go all the way upwards to the cervical region, okay? What are these ligaments here? What's this? That are interconnected between vertebrae, bodies of the vertebrae. What are those ligaments part of? What structure lies between vertebrae? An articular disc, or a disc, I should say, not an articular disc, but a disc, okay? There are two parts of that disc. There's the center, you know, what's the center of a intervertebral disc called? You know? Nucleus pulposus, and then it's surrounded by these dense ligaments. What is that called? An annulus fibrosus, okay? Where did the nucleus pulposus come from? Developmentally. The notochord. The notochord is left behind as intervertebral discs, okay? And it's held in that place by these dense fibrous bands, and then on the inside and the outside, posterior and anterior longitudinal ligaments. All right, so let's see. Okay, so over here, once again, here is an anterior longitudinal ligament. Here's a posterior longitudinal ligament. Here's this annulus fibrosus sitting in here. In the center is this nucleus pulposus. This is the articular disc. Okay? So, yes?
The one in yellow will be that?
The one in yellow is the annulus fibrosus. Okay, that's the ring of tissue. Annulus means surround, a ring, okay? So it's a fibrous ring of tissue. And nucleus pulposus is actually very aqueous. What happens when you get older? What happens to your tissues? Particularly when you get up into your 60s, 70s, 80s, 90s. What happens? Do you turn your tissue cells over quite as frequently? No. They kind of disappear, don't they? So what do? You dehydrate. Okay, these tissues in particular dehydrate. So nucleus pulposus is actually very aqueous. So it dehydrates too. So what do you think happens? What do you think happens to you as an organism as you get into these older ages? Okay. You shrink.
Yeah.
You shrink, okay? So, you know, you were growing up and, you know, depending upon, you know, if your grandparents were still around, you might have noticed that, you know, for a while you probably didn't notice it because you were growing and you were getting taller. And you might have had a grandparent that was as tall as you. But then you stopped growing and your grandparents seemed to get smaller because they were shrinking. Okay? That causes problems because it reduces the space in between vertebrae where the spinal nerves are coming. So that's what causes a lot of spinal-related, nerve-related damage. Okay? So this nucleus pulposus is very, Becky, do you have a question?
Yeah, did the annulus fibrosus also come from the notochord?
No.
Okay, just the nucleus pulposus?
Yeah. So then we have on the back of the spines, we have, let's see if I can find another color here. Back of the spines, we have the supraspinous ligaments. And then in between the spines, we have these ligaments that are between the transverse processes of the vertebra, or between the base of the spines. Here. So these are called intraspinous ligaments. I don't think he has a label. Yeah, he does. Intraspinous. Between the base of the spine, so there's a ligament that goes to the tip of the spine. And then between the lamina on the back of the vertebral, on the spinal cord. We have these ligaments in here. Between the lamina. And these are actually, one of the reasons I'm drawing them in yellow, they're called the yellow ligaments, the ligamentum flavum, okay? The ligamentum flavum. What's different in that, in relationship to other dense ligamentous connective tissue? What's different about these ligamentum flavum? Why are they yellow? What's in them that makes them yellow? Any idea? Okay. Well, does collagen really come out looking yellow, dense collagenous tissue? It looks more gray-white, right? Okay, these are yellow. What type of tissue entity in terms of ligaments is more yellow? Elastin. So if there's elastin here, what does that imply? Why? Why? There, okay? Between the lamina. Okay, we've cut through the front, cut the front of the vertebrae off. We're looking at the lamina. Behind the lamina would be spines. Would be these structures. Here they are here, okay, in the sagittals. Okay, so the body has allowed for some ability to recoil after the vertebral column is stretched. And the elastin is like putting rubber bands and allowing you to have some stretch of your vertebral column. Collagen, when collagen, dense collagenous tissue is stretched, it stays stretched. Elastin does not, it recoils, like a rubber band. Okay? So these ligamentum flavum are kind of interesting, and this is one of the only places in the body where we see that. Where we see these elastic ligaments, yes.
And when you say flexibility and recoil, is it vertical recoil or rotation?
Well, it's pretty much held together tightly in the front, right?
Right.
But we have some ability as we move forward, in particular as we flex our vertebral column, that we were going to put some forward flexion on the back of the vertebrae themselves. As we stand back up, this helps us pull us back up actually and become more vertical. Okay? So it's kind of an interesting, kind of a very interesting arrangement. All right, let's look at the top here. So we had here's the anterior longitudinal ligament that becomes, as it gets from the first cervical vertebrae, its anterior arch, it goes to, this is the occipital bone, here's a foramen magnum right here, okay? And it goes from this vertebrae to the occipital bone, so it's called the anterior gland-occipital membrane, but until it gets there, it's the anterior longitudinal ligament. Now this is outside, this is the front of the vertebrae, this is where the bodies are. If we go on the inside of the bodies, we have this posterior longitudinal ligament that comes up. Here it is crossing behind the odontoid process, the dens, and it is crossing over the back of the dens and creating a roof as it's crossing the dens that's going into the foramen magnum and attaching to the front of the occipital bone, but not outside, but inside. So it's forming a ligamentous roof or a tectum. So it's called the tectorial membrane, the roof membrane. Okay? And so it's helping to hold, these two are actually helping to hold the vertebral column together, in particular in the highest portion. Now, it's also covering this structure, which is a transverse portion of the cruciate ligament, okay? So let's look at this now. Let's pull the posterior longitudinal ligament away. And here is the occipital bone, here. Here is C1, here is C2, and here is C3. And coming across from side to side in C1, behind the dens, behind the odontoid process, is this very thickened ligament that is attaching from each side of C1 to hold the odontoid process against the back of the front of the first cervical vertebrae. It's holding them together. Okay? So it's right against the dens. Here's an apical ligament. Apical means from a point of an apex, like the apex of a root. Here, this is the apex of the spine. And then we have alar ligaments coming out to the side. This, once again, is foramen magnum. So wing-like structures coming out the sides from the odontoid process. And then there's usually some type of a ligament that comes down here as low as C2, but possibly as low as C3. But all of this is covered up by the posterior longitudinal ligament, which will form the stectorial membrane over here inside. And we'll see this in a sagittal view within the confines of the lab. So this is what this transverse portion of this cruciate ligament looks like. This was drawn in as an illustration. So the vertebral column is here. This is now out here. This is C1. Okay. Down below it, we can just see the inside border of C2, but coming up from the body, this is the odontoid process of the dens. And then we have this transverse portion of the cruciate ligament crossing from one side of C1 to the other side of C1 inside the vertebral canal, and holding the dens to the anterior arch of the apex of the first cervical vertebrae. Now you notice what they've also drawn in here. These are actually synovial cavities or bursa. Okay? This articulation is a synovial articulation, just like your elbow, your shoulder, your knee, your thigh. This is a synovial irrigated articulation. Okay? So these are actually bursa sacs, just like you would see in the shoulder. Okay? So, and here is this is the upper facet for C1, so this the occipital condyles would see. All right, so that kind of takes us from the end of that lecture the other day in regards to deep neck structures. This is probably as deep as we can go. So let's go and go to go and start looking at an area which is closer to home, so to speak, and that is the pharynx. That's the throat. Okay? And as we look at this, in relationship to this region, now we're going to look at a lot of heads that are split down the middle, that are sagittally split. Okay? And so we see here the nasal, oral, and laryngeal region. Sometimes the larynx is referred to as the hypopharynx. This area up here is the nasal pharynx, and this area here is the oral pharynx, or the nasal throat region, the oral throat region, and the laryngeal throat region, the hypothroat region. So we've got here with this nasal cavity, which we're going to spend most of our time on this afternoon, we have really three regions, okay? We have this region here. This is called the nasal vestibule. We have this region here. This is called the nasal referred to as the nasal cavity. And then we have this region here, which is referred to as the nasal pharynx. Nasal vestibule, by the way, is heavily vascularized with an arterial branching of the maxillary artery called Kisselbach's plexus. I told you my dog this year, he tried to kill me. He pulled me down, face down on the pavement, and so I thought it was going to bleed out. I mean, that's how fast those vessels dilate due to injury and things like that. But also, we are pretty much in an environment which is chronically irritating our mucosal surfaces, so they're already somewhat vasodilated. So when that happens, you really get a lot of bleeding very fast. But the nasal vestibule, what's surrounding the nasal vestibule? This structure out here, which is anatomically called your proboscis, your nose. Okay? In here, we've cut down the midline, so we've got this separation, because this is a bilateral region. This is referred to as the nasal septum. Okay, we'll talk about that in a minute. It is made up of a cartilage. Here's the nasal septal cartilage and two bones. This bone is the vomer, and this bone is the perpendicular plate of the ethmoid bone that make up this midline bony portion of the septum, along with this cartilaginous hard tissue. These three structures make up the nasal septum. And then we get behind the nasal cavity. The floor of it is made up of the maxilla and the palatine bone, and hanging off the back is a soft tissue structure referred to as the soft palate. And then we're out here into this region that we refer to as being the pharynx. This little opening here, we'll talk about, this is the auditory tube. This is the opening of the eustachian tube. What do we need that for? What do we need that opening for? Bless you. Okay? What is that for? Where does this is the lower portion of the opening, where's the upper portion of the opening?
Here.
No. What's in front of there? What region's in front of the, or I should say behind it? What's the barrier between the external auditory meatus and the middle ear chamber? What's that called?
Pectoral membrane.
How about a tympanic? Okay, so on the inside of that, we refer to that area as what? That's the middle ear chamber. Why do we need a tube from your pharynx to your middle ear chamber? What's the problem we've got? Pressure. Okay, so air pressure on the outside of the tympanic membrane has to be countered by air pressure in the middle ear chamber on the inside of the membrane to keep it from being stretched in one direction or another, so that when sound waves hit it, they aren't obtunded, they aren't lessened. Okay, so it helps to maintain the integrity of the tympanic membrane. You ever have a cold? Your pharynx gets inflamed. You can get those bacteria up into your middle ear chamber this way, okay? Or you can get this area swollen so it blocks the opening, okay? So it blocks the opening. We'll talk about a muscle that helps to keep it open. But this auditory tube is a very significant thing from the standpoint mainly of maintaining a constant air pressure on the inside of the tympanic membrane in the middle ear chamber. All right, so this down here out in front of the tongue, this is the oral vestibule. This is the oral cavity. Okay, and then back here, behind the tongue, this is the oral pharynx. So we've divided, now we've got this area below the nasal region, now we've got the oral region. Then we have this region here that's really between the tongue and this flap of tissue called the epiglottis over here. And this opening here is into what we refer to as the airway. And this opening here is an opening into basically the food tube or the esophagus. And then as we come down here, we go to the trachea and the esophagus. Okay, so these are three regions we're going to be looking at, okay? Christina Wolf is going to go over the oral cavity and the hypopharynx with you. Yes. By the way, the formative will go, it won't include the radiology, but it will include the orbit and the ear. Okay? Okay, so everything from the skull to the orbit and the ear, but not the radiology, not Dr. Sayan's lecture. That'll be in the next formative exam. Okay? All right, so let's look at some structures here on the inside of the nasal cavity, and then we'll take a short break. So once again, we went over these regions. We got the nasal vestibule surrounded by your nose itself, nasal chamber on the inside, nasal air sinuses. We'll talk about those. Those are actually grow in here. When you're a neonate, are there any visible air sinuses? No. Okay. I don't know what they talk to you. There's a lot of different theories about what air sinus is about. Some of them say it's in relationship to allow for differential growth of your midface, because that's where most of them are, associated with the front of your face and the middle of your face. Or they actually wind up creating a reduction in bone thickness in the front of your head that lightens your head and takes pressure or weight off of the muscles that have to keep your head up all day. Okay? So two theories, but there's in a neonate, we still haven't gotten the air sinuses. Okay? Probably we don't start seeing them until maybe 10 years old, 9 or 10 years old, and then we have the nasal pharynx region. Okay? Inside the nasal cavity, we're going to see structures called concha or turbinate bones. Okay? These are bones that create and filter air as it's coming in through your nostrils, through your nasal cavity, and into the upper portion of your airway. Underneath each one of these concha is a space. These spaces are called choanae or meatus. So there's a superior, you see there's three concha, superior meatus, a middle meatus, and a inferior meatus. And then in the back in the pharynx we have the opening of the auditory. So innervation here, well, we saw some of this. The olfactory nerve branches, remember the anterior ethmoidal nerve kind of gives away to these internal nasal and external nasal branches that are associated both with innervating the bridge of your nose, the external nasal, and the internal nasal, the mucosa on the inside of the vestibule of your nose. So this is all in relationship to the olfactory nerve. I'm sorry. Let's correct that fast. I'll do this again. trigeminal give off, this is the nasociliary branch.
So instead of
Gives
it,
off this anterior ethmoidal nerve, which gives off innervation to this nasal vestibule. The olfactory nerve branches are associated with a sensation of smell. That's a special sensation. They are high up in the area of nasal cavity, the anterior nasal vestibule, and they're associated with a sensation of smell, detecting odorants. Talk about that more when we talk about taste and smell in neuro. Trigeminal, we've got also in the nasal cavity, we've got branches of now of B2. So these are referred to as superior, middle, and posterior nasals, and also the nasal palatine. So the nasal palatine comes down on each side of the nasal septum. The posterior nasals come down on the lateral sides of the nasal cavity. Okay? An association we'll see with these concha. And then the facial. Why does the facial get play in here? What's going on? This is a mucosa, right? A mucosa is a secreting membrane. What is the facial nerve in relationship to those secreting membranes? This is a type of autonomic innervation, right? Okay? This is what we call a secretomotor type of function, okay, causing these mucosal glands to secrete mucus on their surface. Nasal cavity, oral cavity is where we have all of this either mucus or saliva to keep these tissues moist. Also, interestingly enough, we'll talk about this with smell and taste. If your mucosa is dry, is bone dry, you don't smell things very well. If your mucosa in the oral cavity is dry, you don't taste things very well, because these receptors are referred to as being chemoreceptors. Wherever you have chemoreceptors, you have to dissolve the stimulant in fluid, okay? They have to be dissolved either in mucus or in saliva. So the facial nerve is a secretomotor parasympathetic division of the parasympathetic nervous system that is innervating the mucosal glands. Why do I have it here just under the trigeminal nerve? What do we know about the facial nerve branches? How did they get to where they're going? What do they travel on? Your formative's next week, right? It was supposed to be today. Okay? What do the facial nerve postganglionic fibers travel with? How do they get to where they're going?
heart,
No, that's sympathetic, right? It's postganglionic sympathetic. On the branches of the maxillary division that from a sensory perspective are coming back from the same tissues that these secretomotor fibers are going to innervate the mucosa. So wherever the maxillary nerve branched, it carries with it postganglionic parasympathetic nerves from the greater petrosal branch of the facial nerve, which synapsed in the pterygopalatine ganglion and now are being carried to their effectors. What's one of the effectors that's in the eye that's innervated by the facial nerve? The lacrimal gland. Okay? All right. Blood supply or branches of the maxillary artery. So, Dr. Higgins, what would be traveling on the surface of the maxillary artery?
Sympathetic.
Sympathetics. Okay. Innervating these arteriolar beds, these arteriolar vascularies. Bless you. All right, why don't you take a 5-minute break?
well,
There's no clinical profession that looks like the head and neck in the detail that we do. Yours is okay. Even things associated with neurology, they miss things because they really haven't had it in their curriculum. You can take, I think you've got just about, what do we got? About two months. Can't remember what, about 6, you've got about 12 weeks of head and neck. Medical school has 6. Okay? That's why I worry about the philosophy that physicians could learn all of their anatomy from the HoloLens. Okay? I never said this before because patients will ask you too what year you graduated, but if you go see a physician, you should ask them what year they graduated and whether they had cadaveric anatomy or holographic anatomy. Okay? I would have a tendency to shy away from the ones that only had holographic anatomy. I mean, I've had a lot of discussions with physicians over this period of time. All right, so now we see cadaver. This is an illustration. Now, all of these surfaces, inside the nasal cavity, inside the vestibule, inside the pharynx, are covered with a very special type of epithelium. What's it called? Did Dandor lecture to you on the respiratory tract? What did he tell you? What kind of epithelium this is? Pseudostratified, ciliated columnar epithelium. That's what you see in respiratory tract, respiratory tissues, okay? So this is all that type of epithelium that covers all the surfaces. All right, so here is the nasal septal cartilage. This once again is the septum. Okay, we've got 2 bones that engage here. Here's the nasal septal cartilage out here. This is referred to as the perpendicular plate of the ethmoid bone. And this is an interesting bone here. This is referred to as the vomer. Vomer looks like a plow blade. That's what vomer means. Okay. And then back here we've got the nasal pharynx. What do you think this stuff is back here? What do you think that stuff is? Back there, the back of the pharynx. Any idea? Okay. Have you ever heard the term adenoid? Oh yeah. What is the adenoid?
Yeah.
Okay. What kind of tissue is it? What kind of tissue is it? Lymphoid tissue, right? Muco-associated lymphoid tissue. Okay, it's basically a tonsil, sometimes referred to as the pharyngeal tonsil. Any of you ever have a TNA procedure, tonsil and adenoids?
Yes.
And now they reduced your ability to fight certain types of bacteria. They don't typically do that unless they absolutely have to. All right, same thing here are these mucosal tissues. Okay, back here. Here is your, let's change color.
Can you make the slide like full screen again?
I will try.
Thank you, I appreciate it.
I see what it does, it's kind of strange. It blows it up for me, but it shrinks it for you. And it goes the other way.
Maybe display.
I got it. Is that better or worse?
No, now you can.
No, it's doing the same thing, right? All right.
You can, whatever work, I don't want it
Here,
to
here
be
I
like
go.
yesterday where like you couldn't see anything, so. Oh, that's better.
Okay, now I've got this one.
Oh.
Oh,
Thanks for taking one for
oh. Okay. So this, what's this looking at here? These are the front of a bone referred to as a concha, a turbinate bone, okay? There are 3 turbinate bones that are in the nasal cavity that pretty much have a more lateral position in the cavity. One that is its own pair of bones is called the inferior nasal concha, okay? Then we have the ethmoid bone kind of wedged in the center. It has the upper 2 concha, the middle concha and the superior concha, okay? So now we've taken out the nasal septum out here. Here's the inferior concha. This is lined with this pseudostratified ciliated columnar epithelium. Here's the ethmoid bone up here. Here is the middle concha. And here is this little bulge here. This is superior concha, okay? So, so this is the inferior concha, or turbinate. This is the middle. And this is the superior. These are both part of the ethmoid bone. Underneath each one of these concha is a space. So this space under here, there's a space under here, there's a space under here. This is referred to as so I erased it. This is the inferior meatus. This is the middle meatus. And this up here is the superior meatus. Then this space in here, this is referred to as the sphenoid air sinus. And between the sphenoid sinus and the back of the superior concha over here is a space or a recess that's called the sphenoethmoidal recess. So we've got concha here. That's great. Okay. Meatai underneath them, okay? what's the role of the nose in regards to breathing? And respiration.
Filters,
What?
filter,
Filtration. What else?
humidification.
Humidification, because this is a secretory membrane, right? What else?
Warmth.
Warming the air. Okay, warming the air. So, warming the air, humidifying the air, filtering the air. Basically now, the nostrils are surrounded by vibrissae, by hair. They're there to filter large particulate matter in your environment. These are filtering small particulate matter, small dust particles and things like that, trying to keep this from getting down in your lungs. Things like smoke and things like that can actually clog this relationship up, and you can wind up getting these smoke byproducts or pollution related air byproducts down into your lungs.
So which one does the filtration?
They all do filtration. One, the nostrils are doing large particle filtration. The pseudostratified ciliated columnar, small particle filtration. Okay, so what do we see here? We see, here's the nostrils, here are the large vibrissae, this is the vestibule, here's the nasal cavity. Here, up here, there's the olfactory bulb and tract. These are the olfactory nerves coming through that cribriform plate, and synapsing in the olfactory bulb. So you don't see inside the cranial vault, you do not see olfactory nerves. You see the olfactory bulb and tract. You see the point of synapse with the olfactory bulb. They hang down maybe as low as the middle concha. They are covered by this pseudostratified ciliated columnar epithelium. This is a mucosa. It's a secreting membrane. As odorants come in here, they're dissolved in this membrane, and then you can smell them. Part of the problem we have in industrialized communities or environments is that the particulate matter in those environments is so heavy, it causes your tissues to become inflamed, and as your tissues become inflamed, they swell, and it's much harder for us to smell things in our environment because of that, okay? Because this down here gets swollen, and the air doesn't get up here as well to be dissolved in this mucosa. So, inferior concha, middle concha, and superior concha, this is that sphenoidal sinus. This is the inferior meatus, the middle meatus, the superior meatus, and this area in here is called the sphenoethmoidal recess. We'll look at it in cadaver.
You said sphenoethmoidal.
Recess. Okay, so here are here are the nostrils, nares. Vestibule. Okay, nasal cavity. Here is the inferior concha, the middle, and the superior. Here is the inferior meatus, the middle meatus, the superior meatus, and this space back here between this is the sphenoid sinus. And the back of the superior concha. This is called the sphenoethmoidal recess. Okay, what sits up here? What was sitting there? pituitary, apophysis. Okay, so inferior hiatus, middle hiatus, superior hiatus, and then this little opening back in the pharynx, that is the auditory tube. Tube. Okay. All right, now we're going to go a little bit deeper. The nasal region in particular is surrounded by air spaces. These air spaces are called air sinuses. Okay. Okay. We saw inside the cranial vault, we saw venous return spaces called dural venous sinuses, where venous blood was flowing through them. So they were functioning like veins, but really from a histologic perspective, they do not have the same histological makeup of their internal surface as a vein, or even their external surface. Their external surface is dura mater. Okay? So these are air-filled mucosal lined spaces innervated by branches of the nasociliary branch of V1 and branches of V2. Okay? So we have a sinus in the front, frontal sinus. There's spaces between this diploic space, or what we call external and internal cortical bone. And it's a bilateral space on each side of the midline over the nose. That's the frontal sinus. Underneath the orbit, we have these very large, somewhat rounded or squared sinuses called maxillary sinuses. We have this sinus behind the nasal cavity and the sphenoid bone called the sphenoid sinus. And then between the upper portion of the orbit and the upper portion of the nasal cavity, we have these tiny little bubble-like sinuses called ethmoidal air cells. Okay? So once again, why are they here? Okay? Because they're not here at birth. It takes them a while to develop. You know, have they talked to you about interfacial growth, whether they're there to really create growth spaces for your midface, or whether they're there to lighten your skull? Okay? They still may do it. Okay? So those are the two philosophies on why we have air sinuses. For growth in the mid-space around those sinuses, mid-base around those sinuses, or lighten the skull so there isn't so much weight on these erector spinae muscles like splenius capitis, trapezius, and spinalis capitis in the back of your head. All right, so these are mucosal lined sinuses. So let's look at a frontal section. Okay, here's a neonate. What are the sinuses? No frontal sinus. Okay, so no maxillary sinus. We can't see behind the nasal cavity. There's probably no ethmoidal sinuses. There's no ethmoidal air cells here. Okay, so here we have, there's no dentition that's erupted at this point in time usually. Okay, here's an adult. Here's a frontal section of an adult. Here's the orbit up here. Here's the maxillary sinus down below the orbit. Here are the frontal sinus. Did they talk to you about that? What do they say?
We have in radiology, you can tell by the color of the maxillary sinus if it's like a more opaque white.
Okay, so if it's radiolucent or it's radiopaque.
Yeah.
Okay. That would be, take a while to get there. Okay. But what if you took your panoramic or your PAs and there was no radiopacity? What would you do next? Oh, what would you do first before that? Would you look at their teeth? Okay. What would you look for? Signs of what? Dental disease, periodontal disease. Okay. Okay. You don't see any of that, you got your radiographs, you don't see any type of dental-related disease, okay? Maybe you see on those teeth, now you start to see little radiopacities around the apices of those teeth. And then what's the next step? What would you do? You guys all have mouth mirrors now, right? They're metal, aren't they? They're not the plastic ones we're getting in the butt. Okay. You take the handle of the mouth mirror and you tap on the teeth. And typically, if you get back here around first molar, second premolar, you tap on those two teeth will probably be sensitive if you tap on them, but in front of that first premolar canine will not, because there maybe is a first premolar root, and if you tap on the third molar, if there's one present, or even the second molar, they wouldn't be sensitive. So that's kind of a diagnostic way of telling whether you're dealing with tooth-related issues or sinus-related issues. Okay. So if you determined that it was a sinus-related issue, would you pick up your handpiece at all? Good. Because that would be displaying incompetence.
What happens to the apex of the root when it sticks up into maxillary sinus?
What's that?
When it's sticking up into maxillary sinus, does it change the apex of the root?
The inflammatory process can, create some radiolucency because there's more fluid in there. But the membrane may be irritated. It can be irritated from, let's say, a dental abscess and actually compromised. Or possibly the tooth root might, over the course of time, even just because of occlusal-related issues, that the mucosa may have been eroded away, okay, and be more sensitive to sinus-related problems. All right. Okay, so now we've gone a little bit deeper from medial to lateral, from septum to lateral. We have cut through some of the concha. Here's an inferior concha. This is a straw coming into the inferior concha through an opening. Okay? And here is a straw here in the frontal sinus coming down here into the middle meatus. Okay? And here is a straw coming from the sphenoid sinus into the sphenoethmoidal recess. Okay? So what's this one from? Where do you think this straw started out? Where do you think it started out? Under the inferior meatus. I actually showed you this before in the lab with the needle problem. What drains into the inferior meatus? Were any of you very unhappy after your body's host exam?
Tears.
Did you go in the corner? Okay? Tears. The nasolacrimal canal gets its name because the tears produced by the lacrimal gland pull in the vestibule of the lower eyelid, behind the lower eyelid, and they drain into the nasolacrimal duct in the medial corner of the eye, and they drain down here into the nose. Okay. So this is from the eye, from the nasolacrimal canal, draining down in the inferior meatus. Okay. So, the nasolacrimal canal, is that a sinus? Is the nasolacrimal canal a sinus? No. Okay. Just a duct. Okay. Then here, this probe is coming down here from the frontal sinus and coming through a duct and bone into the middle meatus. Okay. Okay, so frontal sinus. Sinus is draining into the front of the middle meatus. This duct that is coming down here is called the frontonasal duct. Frontonasal duct. Okay? Now, we've cut away the top edge of the middle concha. We've cut it away right here. And so we've got this pretty much some of the body of the concha, and we've got this bulge underneath, that would have been underneath that flap of that concha. And that bulb has a name. It's called the ethmoid bulb or the ethmoid bulla. We'll see that in the cadaver. Okay, we'll see all of this stuff in the cadaver. Okay. The illustrators went crazy when I tried to get them to draw that for the whole lens. They finally got it. Okay. And let's see. Let's just. Then in the bulla, there's an opening. And that is the opening for some of these anter-ethmoidal air cell sinuses, okay? The anter-ethmoidal air cells are draining through that bulla, through that ethmoid bulla, that ethmoid bulb. Then up here, we can't see it really well. Here, 10, they're showing a little opening here. I'll try and highlight it real quick with the ink. This is actually into the superior meatus. This is from posterior ethmoidal air cells, draining into the superior meatus. Okay. And then we have this probe back here, draining into the sphenoethmoidal recess for the drainage of the sphenoid sinus. To the sphenoethmoidal recess. Now, below that bulla, it's a ball, okay? So the below it, it's a curvilinear type of shape. So if we look at that, here, you see that there's a slit, a curvilinear slit underneath the bulla. And that is called the hiatus semilunaris. And that is the opening of the maxillary sinus into the middle meatus. Okay? So in the inferior meatus, the nasolacrimal canal drains. In the middle meatus, the frontal sinus drains, the anterethmoidal air cells drain, and the maxillary sinus drains. Okay? In the superior meatus, the posterior ethmoidal air cells drain into the sphenoethmoidal recess, the sphenoid sinus drains. Yes.
Can you repeat that more slowly?
No.
No. Thank you.
Okay. Into the inferior meatus.
Wait, start with the middle.
You got that?
I already typed
Okay.
it. Okay, what goes in the middle?
Okay. Inferior meatus. What drains in the inferior meatus? Nasolacrimal duct. Okay. What goes into the middle meatus?
Frontal sinus, the maxillary sinus, and then the ethmoidal, anterior ethmoidal.
Right. Okay. What drains into the superior meatus?
Sphenoid, sphenoid?
No,
Sphenoid
that's
air
into the
sinus?
meatus, the posterior ethmoidal air cells. Okay? What drains into the sphenoethmoidal recess?
Sphenoid air sinus.
Sphenoid sinus. Okay? So all of these sinus secretions drain in here. What's the problem with the maxillary sinus? Why is it always such a problem? Not only from our perspective in relationship to sometimes causing posterior tooth discomfort, but why? Why? Where's the opening of the sinus into this middle meatus? We know on the inside it's coming underneath the ethmoid bullet through the hiatus and interneurus. But where is that opening in relationship to the sinus floor? Is it at the sinus floor or above it? It's above it. So we are a primate of upright posture, okay? If we've got a maxillary sinusitis, before it drains, if we're sitting vertically, it's got to fill up, okay? When will it drain? You lean your head back and it drains down your throat. Barry Aspirin called this post-nasal drip. Or if you lean your head forward and it drains out the front of your nose. Okay? So the body is, I can't complain with its design. It's pretty good all the way around, but this was a big mistake. Okay? This was a big mistake, but maybe it was done to us on purpose. All right, so this is the sinus drainage points. Okay, here are these ethmoidal air cells. Here's the sphenoid sinus back here. Here's the frontal sinus. These are anterior ethmoidal air cells. These back here are posterior ethmoidal air cells. And this small area back here is the sphenoethmoidal recess. And here is the inferior concha. So under here would be the middle meatus, and here would be the inferior meatus. Okay. Some individuals will see this in some cadavers. There's not only this hiatus and ulnaris, but there is a lower opening, just a round opening. Now it's hard to tell. Sometimes that's what an otorhinolaryngologist, an ENT will do. They'll make this extra opening for somebody who has chronic maxillary sinusitis, so that now they'll get a little bit better drainage from the lower portion of the maxillary sinus, so it won't create as many issues. All right, let's go deeper. All right, so there's the maxillary sinus. Here are the mucosal lined ethmoidal air cells. Okay. Here's the sphenoid sinus. Here is this space up here. What space is this? Pterygopalatine fossa. This is the descending palatine canal. Okay. So this is coming into the hard and soft palate, and I'm going to show you the nerves there. What's this bone here? What are we looking at here? What bone is this? Okay. This is the sphenoid bone, right? So this is a part of the sphenoid bone, right? What part of the sphenoid bone is it? Are we on the lateral side of the skull? Medial pterygoid plate. Which side? The medial side of the plate or the lateral side? Right, we're on the medial side of the plate. Okay? So we're going to look at this muscle soon. What do you think this muscle is? That's the tensor palatini muscle. It's a muscle that helps to tense the palate and we lift it. What do you think this fold is here? Here's the soft palate. What do you think this folded tissue is coming from? That's the levator palatine. So what's this nerve here? This large nerve? What is that large nerve that this ganglion is hanging on? In the pterygopalatine fossa, maxillary branch of the trigeminal. What's this little nerve coming down in below it, going into the ganglion? That's the nerve of the pterygoid canal, the Vidian nerve. Okay? Okay, so you should learn to slide backwards and forwards. All right, nerves in the nasal chamber, olfactory nerve, sense of smell, trigeminal nerve. What's the primary role of the trigeminal nerve in the head? What kind of function is it serving? Sensory. Okay. It may carry some other entities from other cranial nerves, but its role is sensory. Okay? So the ophthalmic division with its nasociliary branch comes in here, anterior ethmoidal, posterior ethmoidal, internal nasal, maxillary branches with the pterygopalatine fossa passing through here. What's motor? Why do I have the facial under motor? Why is that motor? And what kind of motor is it? GVE, autonomic. Remember, the autonomic nervous system is defined two ways. One, as strictly a motor system, and two, as a two-neuron system. Preganglionic neuron, postganglionic. Okay, here is the anterior ethmoidal. This will typically have a branch that goes through the nasal bones, and this is the external nasal. Okay, that comes off of this anterior ethmoidal, which is giving rise to these internal nasal branches. Okay, so that is V1 branches from the nasociliary. It's believed that this also innervates the mucosa of the frontal sinus.
Which one's the external nasal again on here? I don't know if I can see.
I'm just drawing it as an addition.
Oh, okay.
All right, maxillary division. Okay, here's the maxillary division back here in the pterygopalatine fossa. Did you read that little jingle that I gave you? Snow White and the pterygopalatine fossa, the seven branches of the pterygopalatine fossa. It's posted on campus.
Okay.
It's kind of cute, helpful.
Yes.
Okay, so this is B2. Here's zygomatic. Here's infraorbital. Okay. Here is posterior superior alveolar. Here is middle and anterior. Here's another look coming down from the ganglion. Here's the ganglion. Hang on, B2. Pterygopalatine. These are descending palatine. These three branches here are posterior nasals. Okay. Here's kind of an expanse of this innervation also taking into play the septum. So here we see the same thing with the septum removed. Here are the olfactory nerves. Here's the ophthalmic nerves coming from this nasociliary branch called the anterior ethmoidal. Here is superior, middle, and inferior posterior nasal nerves. Here's descending palatine nerves. Here's the ganglion. Okay. Now with the septum in place, we've got the olfactory nerve is innervating. Sense of smell on both sides. Okay. Here's the olfactory nerve branch of the ophthalmic nerve branch, and the nasociliary anterior ethmoidal coming down in the vestibule. Here's the nasopalatine. Okay. This comes over this little bump. What's this bump behind the central incisors called? Incisive papilla, right? Incisive papilla. So the nasopalatine foramen, or sometimes called incisive foramen, it's actually two on each side of the septum, are in here, okay? So you can inject into the palate here, probably one of the most painful palatal injections. Actually, it's probably the most painful dental injection, okay? Because the tissue's so tight, when you push the fluid in there, it stretches the nerve endings, okay? And to be honest with you, for most cases, you don't need it, okay? So, kind of spare the sword so that the patient doesn't, patient likes you more. But here's this canal. Your anesthetic syringe needle is thin enough to go up the nasopalatine canal and into the nose. Okay, does this happen? Around here, it happens more than it does out in practice. Okay, even by graduate students. Okay, so your patient will be lying back in the chair, and you're doing this incisive papilla injection, and all of a sudden they may start coughing because the anesthetic is flowing back into their throat. Okay, I guess if you are doing a rhinoplasty, that's not a bad thing. Okay, because you will numb out nasal septum. But if you're doing dentistry, that's not a good thing. We've got coming up shortly, here are the branches of the maxillary artery, following the maxillary nerve branches into this area. We're gonna be doing an anesthetic, local anesthetic exercise on the cadavers, and you'll be able to push the needle wherever you want it. The cadaver will not complain, okay? But you'll see, you know, as you're going through tissue, maybe get some feel and idea, position to do these different injections, you know, by starting out with a cadaver. Next year you do it on each other. And after that you do it on a patient. That's probably the scariest one. For you and probably for the patient who's asking you as they sit in the chair, how many of these have you done? And you said, oh, I've done several. I've done several. Okay, so let's try and get in with this posterior pharyngeal wall area, okay, because it's significant, and then Dr. Wolf will continue it down into the oral cavity. Okay, so there is a muscular wall covered with mucosa behind the nasal cavity, behind the oral cavity, and behind the hypopharynx or laryngeal cavity, okay? And this skeletal muscle came from branchial arches. Okay? So it's SVE innervated. It's pretty much SVE innervated by two cranial nerves, cranial nerve 9 and cranial nerve 10. Interesting, most, at least anatomy texts, don't give cranial nerve 9 a lot of play in this, but all of the dissections that they show you show cranial nerve 9 going into it, into the muscles. The one that gets the most play from cranial nerve 9 is called the stylopharyngeus. That's also a posterior pharyngeal muscle. So these are called constrictor muscles. Okay? So we're starting up here. This is the highest point of the airway. As we come down, the airway is running parallel to the food tube. Not a real good idea, okay? But that's how we are designed. That's how we are designed. So what happens here is the peristaltic waves actually descend from this highest point of the throat, of the pharynx, and go down. And we have got to get the air into the anterior tube, the larynx. Okay, that's the valve protecting the airway. And we've got to get the food from this space below, behind the larynx, into this tube we call the esophagus. Okay? So how is the digestive tract designed? Is it an open tube or is it a closed tube, like a hose? It's like a hose, right? Respiratory tract, the same thing. We get down to the lungs. Are these open tubes or are they closed tubes? Okay? So we've got to do something up here to create some closure of these tubes in the front when we breathe or when we swallow, particularly when we swallow. So these muscles are actually like half a digestive tube, half a GI tube. We've got the muscles in the back, and the only way we can close the front of the tube is by closing off our mouth when we swallow. we've done this exercise before. When you swallow food, your teeth have to be together, your lips have to be together, your mouth has to be closed. Okay? So these constrictor muscles, as they're stimulated by the food hitting them, will then create this wave of peristalsis and hopefully push the food down into the posterior tube or the esophagus. Okay? So what's the problem? Well, today's society, we do everything in a hurry, or we multitask, okay? So, have you done an exercise in, what is it? Oh, the ABCs in relationship to basic life support?
Yes.
Have you done that? Okay. Did you do the Heimlich maneuver?
Yeah.
Okay. How does that happen? Why does that happen? Why do we get food in our larynx? What are we trying to do at the same time we swallow? We try to speak, okay? So basically all these, like power lunches, breakfast, whatever, when you're carrying on these conversations, at the same time you're eating a meal, they basically can kill you. Because if you decide to breathe at the same time you swallow, the airway will be a little bit more open, and that puts at risk the airway aspirating the food into the upper airway or into the larynx, and causing laryngospasm and causing blockage of the airway. So it's kind of it's a very complex thing, in particular in humans, to do this. And these muscles here, we've got these constrictor muscles, which are kind of the correspond to the circular muscles of the digestive tube. Okay, so these are, the circular muscles. And we know in the GI tract we also have longitudinal muscles, which kind of pushes things along. These are the longitudinal muscles, something with pharyngeus, palate-pharyngeus, and stylopharyngeus. Okay, so these are the muscles of this tract. So let's just take a quick look at them, and then and here is kind of a makeup of these muscles from the standpoint of their points of attachment. Okay. But this is kind of what I was talking about. We're looking from the back. So we're now looking from the back and we're looking forward. This is the back wall of the pharynx. This is the superior pharyngeal constrictor. And it overlaps from the front, the middle pharyngeal constrictor, and the middle pharyngeal constrictor from the front overlaps the inferior pharyngeal constrictor, which you can sometimes see in the lateral borders of the larynx of the thyroid and cricocartilage. Here's the thyroid gland down here. This is called the cricopharyngeal junction right here, and then down here, this is the esophagus. Okay. So we make a transition from here, from skeletal muscle to smooth muscle. So once we make that transition, it's out of our control. We can't get it back. We can't get what we swallowed back, okay? And it will continue as long as it's in the esophagus. It will continue this peristaltic wave because we're stretching the tube. We're stretching this smooth muscle tube, and that stretching will cause it to elicit another peristaltic wave until the food has cleared the esophagus and is entering the stomach. Did Tim talk about this at all in GI? Okay. So, why I say the glossopharyngeal nerve doesn't get much play. Here's the glossopharyngeal nerve. This is superior pharyngeal constrictor, middle pharyngeal constrictor, inferior pharyngeal constrictor. So it does play a role here. Also the vagus nerve plays a role here. Okay, here is this superior cervical ganglion again associated with the vascular. So these are all skeletal muscles. It's kind of interesting that they overlap. The highest one overlaps the lowest one overlaps the next lowest one. Why do you think that's significant? What if it was the other way? Because look at it here. What if it was like this? What would be the problem, potential problem? When we swallow, we possibly create folds between the constrictor muscles, and then food can get caught there. So it's actually, once again, it's a pretty good design to have superior overlap middle, middle overlap inferior, and so forth. Okay. And here's a look at the anatomic aspect of it with basically a visceral tube pulled out. Just show you this last one because this also is rather significant. So here are these constrictors. Here's superior. There's a little bump on the underside of the occipital bone called the pharyngeal tubercle. Why is it called the pharyngeal tubercle? Because on each side the superior pharyngeal constrictor attaches to it. So this is the pharyngeal tubercle. Comes down. It also, as it's coming out lateral, attaches here the pterygoid plates. Here's the medial pterygoid plate. Okay? And so lateral and medial pterygoid plate. This is lateral, this is medial. What do we have on the end of this medial pterygoid plate? We have a hook. What do we call the hook? Annulus. So this comes down, attaches to the annulus, then it comes down and it engages this muscle out here that's in your cheek. What do we call this thick muscle in your cheek? Buccinator. And what do we call this muscular attachment between the two muscles? The pterygomandibular raphe. Pterygomandibular raphe. Okay, when we do it, and we'll talk about this with injection, here's the mandibular foramen. We want to inject lateral to the pterygomandibular raphe so that we can stop the needle at bone and then slide it back to the inferior umbilical foramen. Here is the medial pterygoid plate. Here is a muscle coming down to the soft palate. Here's the soft palate hidden behind here. It is coming down on the side of to the top of the soft palate. This is called the levator palatini muscle. And here is a muscle that loops around the annulus that comes into the side of the soft palate. And this is called the tensor palatini muscle. We'll see these more from an anterior sagittal view when we get down in the lab. Okay, here, down here, we're already past the oral cavity. Here's the soft palate. Here's the uvula. We're looking at the back of the tongue. Here is the middle constrictor coming down, and then it's overlapping the inferior constrictor that takes it all the way down to the laryngoesophageal junction. So we're going to be looking at these muscles here once again as a medial pterygoid, the masseter, and the lateral pterygoid up here. So we're going to see all of this stuff in the laboratory. Okay? We're going to see all this stuff in the laboratory. And we're actually going to talk about it again because we're going to talk about the anatomy of speech and swallow. All right, I'll let you go home and rest now.